So the presenters are Sai Anila and Hamdam Rishi. Okay. So it is on upper GI bleed. Upper GI bleed. The first part consists of etiologies or the causes behind upper GI bleed with the clinical features. Okay. And the second part consists of investigations and management in the casualty. So what are you going to do when the patient comes in the casualty? What are the resources over there? You'll have an idea what you can do for the patient in the casualty. Okay. So there are two more topics which we'll be covering in the next symposium. So in this symposium we'll be covering these two topics. One is the causes of the etiology behind upper GI bleed and clinical features. Second is investigations and management in the casualty. Okay. So what is GI bleed? Can anyone tell what is GI bleed? Bleeding from the GI tract, bleeding into the GI tract, bleeding from the GI tract and bleeding into the lumen. Okay. So the source of bleeding is there in the GIT, which includes starting from your lips till the anal canal. Okay. And it is not bleeding outside the GI tract. Okay. It is bleeding into the lumen of the GI tract. Then we tell it as a GI bleed. Now, Aina will be covering what is upper GI bleed and what is lower GI bleed. Okay. But why is this topic important for surgeons? This particular disease condition, that is a GI bleed, carries a lot of morbidity and mortality. Okay. Most of it is managed by intervention radiologists, by endoscopists. Surgical management is also there, but early involvement of the surgeon has been found to reduce the mortality, the hospital stay, and having a definitive management of the patient if needed. Okay, so that is the importance of GI bleed in surgery. So we are discussing it. We might have discussed it in medicine also. This topic has also been covered in medicine. But why it is important in surgery? This is the reason. Okay, if we know what is the definitive management, okay, like there is an ulcer, peptic ulcer disease, it's bleeding. Now you have given medical management for this patient, you have given Pantop. Okay, you found that the ulcer is because of Helicobacter pylori. You have given that. But there are some situations where these won't respond to these drugs. Patient is going to come with recurrent episodes of bleeding. So we have to find out those scenarios and do a surgical intervention at an earlier date, thereby minimizing the morbidity and mortality, hospital stay, as well as the expenditure of the state on the health of those patients. Okay? So that is the reason this topic is important. So I'll hand it over to the presenters.
Good afternoon, I am Anila and I am going to talk about the etiology and clinical features of upper GI bleed. The gastrointestinal bleed, like sir said, when it occurs, it can either be upper GI bleed or lower GI bleed or obscure bleeding. So, coming to the upper GI bleed, what is upper GI bleed? The gastrointestinal bleed occurring proximal to the ligament of Treacs is called upper GI bleed. So, we all know ligament of Treacs is a fold of peritoneum which extends from the right crest of diaphragm to the duodenal jejunal flexion. Coming to the etiology of upper GI bleed, the causes can be classified as non-varicose causes and the varicose causes. In this diagram, we can see various causes which are leading to the upper GI bleed. As you can see, peptic ulcer disease contributes the most, and it is a non-variceal cause. So we say that non-variceal cause is the most common cause of upper GI bleed. These are the various non-variceal causes. We'll be discussing about each of them like briefly. Coming to the peptic ulcer disease. Peptic ulcer, the definition is the disruption of mucosal integrity of stomach or duodenum, leading to a local defect which is due to acute inflammation. So this is mostly due to H. pylori, as we all know, and it can also be autoimmune. And clinical features include pain. The patient presents with dull burning type. It's a burning type of pain in the epigastrium region, and bleeding is it's hematemesis, or they can also present with melena, which is black tarry stools. And periodicity, it means that sometimes the patient, the symptoms will subside for a few weeks or months together, and then they recur suddenly. The patient may also complain with vomiting. As we said, peptic ulcers can occur in duodenum as well as stomach. So, and duodenal ulcers have more tendency to bleed than the gastric ulcers. The source of bleeding is, in duodenal ulcers, it's the gastroduodenal artery, and in gastric ulcers, it's the left gastric artery. This is the endoscopic view of gastric ulcer and duodenal ulcers. You can see the excavation there, and also the duodenal ulcers. The second cause of hematemesis is gastritis. Gastritis can be classified as acute gastritis or chronic atrophic gastritis or uncommon forms of gastritis. Acute gastritis is mostly due to inflammation, and it's bacterial in origin due to H. pylori, and some other bacteria like H. hirmani can also cause acute gastritis. Chronic atrophic gastritis can be two types. It's type A and type B. Type A is autoimmune, and type B is bacterial usually. And there are some uncommon forms of gastritis are lymphocytic, eosinophilic, and sarcoidosis. Mallory Weister, it's usually mucosal and rarely submucosal. It's a mucosal tear which extends from it is a vertical tear which extends from the gastroesophageal junction and towards the cardia of the stomach. And it is usually seen after forceful vomiting and alcoholic patients, and also in pregnant ladies sometimes. It is usually self-limiting, and the patient presents with hematemesis. Gastric antral vascular ectasia, as the name suggests, it occurs in the antrum, and ectasia, it's dilatation of the venules. It is more common in females, and it also has a characteristic appearance called watermelon stomach. You can see in the picture that it looks like a watermelon. Another cause of hematemesis is Dieulafoy lesions. The gastric antral vascular ectasia is venous in origin, and this is arteriolar in origin. Here the submucosal arterioles, they protrude into the lumen of the stomach or duodenum in the stomach. They protrude most commonly the body of the stomach is involved. It is seen in males and elderly, usually in the 6th to 7th decade of life. It also has a characteristic appearance called strawberry stomach or snakeskin stomach. And also malignancy also can present with hematemesis. Malignancy not usually presents with like a lot of vomiting up of blood. It's either melena, and chronic cases usually present with anemia. And sometimes, if it is a case of gastrointestinal stromal tumors, which are tumors of connective tissue, like they are sarcoma, they can present with ulcerative lesions which bleed persistently. And while these tumors can be missed through endoscopy, so CECT is the investigation of choice for this. So coming to the variceal causes, obviously varices develop due to portal hypertension, and so portal hypertension can either be extrahepatic or intrahepatic. Extrahepatic causes include portal vein thrombosis, splenic vein thrombosis, tumors, and we know that portal vein is formed by superior mesenteric vein and splenic vein. So splenic vein thrombosis will also cause the portal hypertension. Intrahepatic causes can be classified as pre-sinusoidal, sinusoidal, and post-sinusoidal. Pre-sinusoidal causes include non-cirrhotic portal fibrosis, ascariasis, and schistosomiasis. Sinusoidal causes include it's due to cirrhosis of the liver, which leads to portal hypertension, and this cirrhosis can be due to alcohol or viral origin and Wilson's disease. So post-sinusoidal causes include constrictive pericarditis, IVC obstruction, or severe tricuspid regurgitation can also lead to it. Now coming to the clinical features, what the patient presents with. Patient, as our topic it is, upper GI bleed, they present with hematemesis, which is vomiting the blood. Hematemesis, and if by the color of the blood they are vomiting, we can say whether the bleeding is rapid or it is less severe. If they are talking about, if they are vomiting red clots, then the bleeding is rapid, and if they are vomiting like black like coffee grounds appearance, if it has, and then it will be like we can think the bleeding is less severe. So they can also present with melena, black, tarry, foul-smelling tools, and hematochezia is it's passage of fresh or altered blood through per anus. So usually this occurs in the lower GI bleed, but if the upper GI bleed is very extensive, even then the patient can present with hematochezia. The patient has abdominal pain, and weakness and breathlessness include. These are due to anemia that the patient develops due to loss of blood. And symptoms, as we said, we also know that peptic ulcer disease and gastritis can be caused by NSAID. So antecedent drug usage can be present, and antecedent vomiting, as peptic ulcer disease has vomiting. So because of it will point to the cause of the disease, cause of this upper GI. Weight loss like malignancy, and known history of liver disease, so that we can check for them. It can be either variceal or non-variceal. We'll know about that. Now coming to the signs are not very common. So pallor, as I said, the patient loses a lot of blood, so the patient will be anemic, so we'll be able to elicit the pallor. And ascites and splenomegaly, we can say it is due to portal hypertension. We can appreciate them. And we all know the features of liver failure include jaundice, which is yellowish discoloration of sclera, mucosa and skin, alopecia, loss of hair, spider nevi are the dilated arterioles which are seen on the skin, and gynecomastia is the enlargement of breast in male, and caput medusae, it's like the dilate, you can see around the umbilicus, the dilated veins are visible due to portal hypertension. Leukonachia is whitish discoloration of nails, and palmar the casualty treatment and investigations will be continued by after.
Okay, that was a sweet and concise presentation. Okay, can we move on to the first slides? So GI bleed has been broadly divided into upper GI bleed and lower GI bleed. Okay, upper GI bleed 80%, lower GI bleed around 20%. Okay, the most common bleed, most of the 80% of the severe bleed what we see in the casualty, it will be an upper GI bleed rather than lower GI bleed. Okay, so what is this obscure bleed? Yeah.
Obscure bleed is like we don't know the cause. We get an occult bleed in the feces or.
Now there is a difference between obscure bleed and occult bleed. Yes, anyone? Yes.
So in occult bleed, the blood is not visible through the naked eye, and in obscure bleed, we are not sure where the exact location of the bleed is because it's showing symptoms of both upper and lower GI bleed.
He said that in occult bleed, there is something which is happening microscopically and we are not able to see it in our naked eyes. It means that hematemesis may not be there, melena may not be there, or hematochezia may not be there. Okay, so this part is correct. Okay, that is occult bleed. Microscopic bleeding, which is not evident in the form of hematemesis, melena, or hematochezia, but patient presents to you at a later stage with anemia when the symptoms of anemia are manifested. That is occult bleeding. So what is obscure bleeding? He said that we have done some investigations and we are not able to find out the site of bleeding. Yeah, there is some sort of correct even after doing endoscopies. Okay, that can be your cholecystoscopy or a colonoscopy, you are not able to find out the site of bleeding, but there is hematemesis, there may be melena, or there may be hemoptysia. Bleeding is there, but you are not able to find out the site. So what you think is that maybe a small lesion, you send the patient home, patient again comes with a rebleeding. Then also you are not able to find out. So that is obscure bleeding. Bleeding, you know, we have confirmed that bleeding is there, but you are not able to find out the site. Very good. Okay, so that is obscure bleeding. Yeah, next one. Ligament of Graves. Okay, fine. Yeah, next slide please. Varicose. Yeah. So around 80% it's non-varicose and roughly 20% is varicose. Next. So the varices here has come down to 2 to 9%. So that is slightly higher. It's around 20%. Okay. We'll consider that to be around 20%. Peptic ulcer disease includes both peptic ulcer as well as gastritis. It amounts to around 40 to 45%. Okay. So this was taken from I think 2004 edition. Na? That is why I think old one. Okay. So varices contribute to 20%. The reason may be that now we are seeing more patients with chronic alcoholic liver disease. That may be the reason. Next. Okay, yeah, the most common is peptic ulcer disease, which amounts to 40 to 45%. And the next common includes your other things like your gastritis, even your varicose bleed amounts to the second most common cause, but a severe form of upper GI bleed. When the bleeding is severe, it means less common, but the bleeding is severe. Okay, next. Okay. Yeah. So what happens is that in any ulcers, okay, the bleeding won't be that severe. In peptic ulcer disease, the bleeding is not that severe unless it is the ulcer is located just above a main vessel, like in the duodenum, superficial to the gastroduodenal artery. Gastroduodenal artery is a branch of, yes, common hepatic artery. So GDA is a branch of common hepatic artery. Okay. So if there is an ulcer just superficial to the GDA, then when it erodes deeper, it is going to erode into the GDA, thereby resulting in severe bleeding. Similarly, if it's something is there along the lesser curvature of the stomach, which is the division of where the left gastric artery supplies, and if the ulcer is there and it erodes in that area, it is going to bleed severely. Okay. Whereas in other locations, suppose there is a body of the stomach, anterior posterior wall of the stomach, where there are no named vessels, there will be some small branches. So these what will be, there will be some small minor bleeding will be there, patient will be asymptomatic, will be having sometimes black color stools, patient won't be taking care of it, and then finally he will present with symptoms of severe anemia to you. Okay, so that is what happens. So when it is corresponding to any artery, patient is going to present with an acute severe GI bleeding. When it is present in other areas, patient may not present even acutely. He or she may present to you late as a case of severe anemia with chronic GI bleeding. Yeah, next please. So that is the stomach. Okay, lesser curvature of the stomach. Okay, so we see this is the lesser curvature. So what is dark, the light is not falling. That is a greater curvature. Okay, this is the first part of the duodenum where you are finding an ulcer in the anterior wall. Okay, next. Okay, next. Okay. Mallory B is clear. So what happens is that why it happens? So there is a longitudinal tear starting in the G junction, which proceeds from the G junction towards the cardia. Okay, it's most commonly seen along the lesser curvature, not along the greater curvature. So how does it develop? Yeah.
She said it's because of vomiting.
Yeah, vomiting.
Maybe because of intra-abdominal pressure increase due to forceful vomiting.
So forceful vomiting will increase the intra-abdominal pressure, but why will it cause tear in that area? Sorry. Okay, it passes through that, fine. But what is the reason behind this tear? Yes, anyone? Yeah.
Lower esophageal sphincter is present as of the gastroesophageal tract. So the vomit is being forced against that sphincter, which is why the pressure is formed on these points.
So when there is retching or the act which precedes vomiting or the act of vomiting also, sometimes what will happen? The abdominal muscles will contract and they will increase the intra-abdominal pressure. Whereas before vomiting, what will happen? The LES will be contracting tightly. So this contents of the stomach are forced against a closed LES. So that produces a longitudinal tear at the G junction, okay, which extends into the cardia. This is usually confined to the mucosa, but when it goes deeper into the submucosa, there may be some severe bleed, and which may persist in 5% of the cases. It is self-limiting in 95%, in 5%. Yeah, it is usually self-limiting. There is a 95% it is self-limiting, in 5% the patient will present to you with severe bleed and ongoing bleeding. Okay. Yeah, next. Yeah, this is fine. So there will previous one. Yeah, there will be longitudinal accumulation of submucosal veins, okay, which will appear red as compared to the surrounding normal gastric mucosa. So this red color you are able to see. So these are the accumulation of dilated venules in the submucosa. Yeah, next. Okay. Snake skin appearance is usually seen in portal gastropathy. Okay. I don't know where you got this references from. Snake skin. Okay. The snake skin stomach is usually seen in portal gastropathy. Fine. So I am not sure regarding the reliability of the source from where he has taken the Delacour lesions look like snake skin. What happens is that around 1 to 4 mm size, these arterioles are there. So they are there in the submucosa, and when there is an ulceration, they bleed. Okay, and they look like that. Okay, there will be it will look like an ulcer, a small ulcer, 2 to 5 mm in size, and a spot, a red spot with some branching. Okay, so that is the typical picture of Delacour lesion. Okay, next. Malignancy. Yeah, next. Okay. There are some other non-varicose causes. Okay, some I would like to. One is hemobilia. What is hemobilia? Yes, hemobilia. The meaning is there in the words. Hemobilia. Hem is blood. Bilia, bile. Blood in bile. So when can you expect the blood in the bile? Yes, blood in the bile. Gallbladder, what? How will gallbladder bleed? Okay, stones, but usually they don't cause any bleeding. You can see that in the urinary tract, the oxalate stones, they have spicules. Okay, that causes erosion of the mucosa of the urinary tract, thereby resulting in bleed. Okay, but in gallbladder stones, they don't have like that, so they usually don't cause any bleed. Malignancy, very good. So if there is a malignancy of the biliary tract or the liver, so that can sometimes, because there's a malignancy, the tumor will grow in size. A part of the tumor will have decreased blood supply because it's rapidly increasing, and the blood supply to that tumor may not be adequate to meet the demand of the tumor, so there will be some necrosis. So necrosis will be there and there will be sloughing off of the tumor, and that will sometimes, if it is close to the bile duct, there will be bleed. Okay, so one is malignancy. Very good. Any other cause of hemophilia? Yes. Any instrumentation can cause hemophilia. Any trauma can cause hemophilia. Liver trauma. Okay. It can be penetrating trauma or it can be blunt trauma. Any liver laceration can cause blood in the bile. Any intervention like ARCP and stenting. So what we do, when we stent it, we do a sphincterotomy, and that time what we do, we injure the sphincter. We cut the sphincter. Okay. So that what will happen is that if it is blood has went is there within the biliary tract, it may actually block the biliary tract, and the patient is present with obstructive jaundice, right upper quadrant pain, and and the patient may also present with upper GI. So these are the three cardinal symptoms of hemophilia. Okay, upper GI bleed, right upper quadrant pain, and jaundice. Fine. Now there is another condition of upper GI bleed, that is hemosuccus pancreaticus. Okay, not that common, but we see many cases like that coming because pancreatitis is very common over here. So if you look at the surgery ward, you will at least find one patient of bleed, hemosuccus pancreaticus, in the surgery ward. Okay. So what happens in this? So you must be knowing about pseudocyst of pancreas. Pseudocyst of pancreas. Okay, so we have to cover that part. Okay, so hemosuccus pancreatitis is one of the non-varicose cause of bleeding. So what happens is that pseudocyst of pancreas is one of the complication of pancreatitis. Okay, so what happens is the fluid gets collected following an episode of acute pancreatitis close to the pancreas, and this fluid later is covered by a wall. After 4 weeks of time, it becomes thicker in size. So that is called a pseudocyst. Okay. Now the pseudocyst can be of 3 types. In the second type and third type, where there is a communication with the pancreatic duct. Okay. So this pseudocyst contains enzymes which are actually secreted by the pancreas, since it is in communication with the pancreatic duct. So this pseudocyst also closely related to the pancreas. You know, the splenic artery is there. So what happens is that because of these enzymes and because of the pressure, the splenic artery, wall of the splenic artery is slowly pushed and eroded. Okay, and later pseudoneurysm develops, and the pseudoneurysm that bleeds into the pseudocyst, and from the pseudocyst, since it is in communication with the pancreatic duct, it will bleed to the pancreatic duct into the GI tract. Okay, so that is hemosuccus pancreaticus. Okay, there are some other iatrogenic causes of upper GI bleed. Okay, any surgery, ARCP and stenting, endoscopic procedures like PEG can also cause upper GI bleed. So these are other causes of upper GI bleed, non-varicose causes of upper GI bleed. Yes, next. Next. Yeah, next. Okay. So, what is this coffee ground color because of? Acid hematine. Very good. So, this coffee ground color of the vomitus is because of the conversion of hemoglobin by the acid of the stomach to acid hematine. Okay. Then why is the melena black then? When it's coming out through the mouth, it has coffee ground color. Okay. But when it comes out per annum, why is it black color? Yes. Okay. So what happens is that this acid hematine undergoes further degradation by the enzymes in the small intestine, and also what happens, the bacteria in the colon acts on it and converts that coffee ground color acid hematin into a black color, okay, which is black, tarry, fall smelling and sticks to the pan. Okay. That is also one of the characteristic finding of melena, that it will stick to the pan. It will be black, tarry, tar-like and fall smelling. Okay. Next. Why is antecedent drug usage important? Yes?
NSAIDs can cause gastric irritation.
Okay, if the patient has been taking NSAIDs for a long period of time, that could be a predisposing risk factor for the development of peptic ulcer disease. Anything else?
We will know if the periodicity of the peptic ulcer is computed positive class.
Okay. If patient is taking any treatment for peptic ulcer disease, you will also find out the diagnosis that okay, this bleeding is there is probably because of the peptic ulcer loading into a vessel. Yes, anything else? Yeah, steroids. Very good. Then SSRIs. Okay. Selective serotonin reuptake inhibitors. So these are the drugs which are known to be ulcerogenic, and history for these drug usage is required. Okay, and also we need to know regarding the liver disease. Okay, patients with chronic liver disease are likely to have a varicose bleed, but still there's a high chance that there may be a non-varicose bleed associated with it. Okay, patients taking warfarin. Okay, though we think the patient comes to you with taking who's on warfarin or heparin, comes to you upper GI bleed, there may not be a coagulopathy, but there may be a GI lesion which has bled, and then but usually you should have stopped spontaneously. But since the patient is on warfarin or other anticoagulation, the bleeding has not stopped. Weight loss, antecedent vomiting history will usually indicate malarial history. Very good. Next. Clinical features. Okay. Next. Yeah. So we'll move on to the next topic, that is casualty treatment and investigations in a case of upper GI bleed. Yeah.
Good afternoon, everyone. Now I will be continuing with casualty treatment and investigations of GI bleed. When a patient comes to the emergency department with the GI bleed, this is how we approach the patient. First, initially we should stabilize them, and then we take the history, clear history and examination. Then we proceed with the resuscitation and the stabilization. Then we localize the bleeding as we find the site, and we start with the treatment and to prevent the further complications. In history, what we take is a history of hematemesis. As she already explained everything, hematemesis is blood in vomit, then melena, then hematochezia, dysphagia, udinophagia, then all of this. And main thing we should consider is there will be anorexia, then syncope, and due to severe anemia will be there, and the patient will be very weak. And examination, as previously explained, we should look for pallor, signs of anemia, then icterus for any liver involvement, then clotting edema, then vitals should be taken. There will be severe tachycardia, then hypertension may be there due to loss of blood. These are the signs. Coming to examination, we look for ascites, spider navy. That's you can see the enlarged capillaries. Then capillary as she said, due to portal hypertension, we can see the enlarged veins over the near the umbilicus. Then hepatomegaly, like as in any liver involvement, there will be hepatomegaly. These are the previously said signs. That's arthritis, spider navy. This is capsule medusa. That's palmar erythema. Coming to the investigations, we take the complete blood count and we assess the hemoglobin level and prothrombin time. If the patient is on any anticoagulants, then we have to take this. The blood grouping and cross matching for, like, if the patient presents with lot of blood loss, we have to supply the fluids or blood. So for that we have to take blood grouping and cross matching. The other investigations are blood urea, nitrogen, serum creatinine, like serum electrolytes. These are important for the GPS scale that we are taking. Will come later. This nasogastric aspiration, like this is both therapeutic and endoscopic diagnostic. For diagnosing to assess the rate of bleeding and assess the severity, we use this. And also, if there is any excess blood in the stomach, we also use this to clear that prior to endoscope also. Several grades are used to assess the severity of the UG bleed. The mainly we use this Glasgow Batchford bleeding score (GBS). It includes mainly blood urea, nitrogen, and hemoglobin, then blood pressure and other history and examination findings like heart rate, syncope, hepatic disease. Usually there's a zero score. Zero also is there. Says less than 6.5 in blood urea, nitrogen, then greater than 130 for hemoglobin in men and greater than 120 in women. Then SBP less than 100, no, greater than 110. Then heart rate more than this, they will be taking 0. If any, usually the total score should be 0. If anything above 0 is there, we have to act like that. And this is the management as we usually do for every casualty. We do the air breathing and circulation, then we put 2 large bore IV cannulas, 16 or 18 gauge. Then we do endotracheal intubation. This is mainly done like while endoscopy procedure. There's a high risk of aspiration. To prevent that, we do endotracheal intubation. Then, as previously said, the patient will be presenting with anemia and severe blood loss, so we have to resuscitate with fluid. Usually we use normal saline or reactor. In severe anemia, we have to supply the blood. For that, these are the criteria. If the patient is on any anticoagulants, we have to take the INR and we have to assess the prothrombin type and we have to suggest the transfusion of the blood according to that. Coming to the medical management, we have to give pantoprazole or esomeprazole, like until the endoscopy is done. This is to prevent the UG, the antifibrinolytics for preventing the anticoagulant effect. As said, endoscopy is both diagnostic and therapeutic. For diagnostic, we can see the source of bleed and we can assess the degree of the bleeding. For therapeutic, we can clear up the blood that is accumulated in the stomach, or also maybe take biopsy for identifying the what causes the bleed. These are the normal endoscopic findings of the stomach. As we see in a normal patient, normal person will be visible like this in the esophagus, the junction, then gastric rugae, you can see the foldings and the andro. While coming to patient with GBLED, there will be esophageal varices as a main cause of GBLED. It will be graded into 3. That you can see this in the next picture. Now I'll just maybe grade 1 is vas extending just above the mucosal level. Grade 2 will be the valves will be projecting into the lumen. Grade 3 will be the valves will be touching each other almost. You can see as I said, this that's only mucosal lumen. This is almost this is projecting into the lumen. This is touching. Then in bleeding esophageal and gastric gases, you can see as the picture and number notates. This is another classification of endoscopic findings called Forest classification. See, 3 grades are there: Forest 1, 2, 3, and 1 is given to 1A and 1B. So you can see as what it says. Arterial spurting will be bleeding from that point. Forest 1B is using from the ulcer basically. There will be an apoplectic ulcer, and the blood will be using from that activity. In severe cases, we have to stop the bleeding immediately. For that, we use temporary hemostatic tubes. The most usually is taken black tube. It has 3 openings, 2 for balloons, 1 for the aspiration. And while doing this procedure, we have to make sure that the tube should be deflated every 12 hours. Otherwise, there will be pressure necrosis due to this. Middle one is the Sangstaken black node. There are other tubes used in Clinton and Minnesota. Then finally, we have to take the CT angiography to find out which artery or which vessel is involved in this. There's one more thing called RBC nuclear tag scan. We tag the RBCs with radioactive material to mark the RBCs, and that way we can detect the rate of bleeding and also what type of disease. Thank you.
It was fine, okay. So we'll just see now where we could have improved. So next time in your symposium, you can keep some questions for the audience, so that they will be engaged. Okay. Some are feeling sleepy, so questions can keep them engaged. So a patient comes to you in casualty, is vomiting in front of you blood. What are you going to do immediately first? Stabilize the patient, or you'll ask history and examine. Stabilize the patient. So first I think should have been initial assessment and resuscitation. Okay, that should have been the first step while resuscitating a patient. While patient comes to you in the casualty. If he says upper GI bleed, that is fine. Then you can examine the vitals and then resuscitate. But if the patient is vomiting in front of you, blood, or is very looks to be sick because of maybe low blood pressure, then the first thing what you have to do is you have to resuscitate the patient. So what are the principles behind the resuscitation? Has already covered A, B, C. Okay. Here, what is going to kill the patient? C. But still, then you have to do a fast check of the assessment of the A and B. A is airway, B is breathing. So, how can airway be compromised in this patient? Aspiration can be done. Why will the patient aspirate? That he will vomit. Every vomiting patient doesn't aspirate. So why will we worried about A? Yeah, a patient who has bled. Okay, if the patient is in class 3 or 4 shock, then there can be some confusion, or the orientation may not be good. Okay, if the patient is a case of chronic liver disease, then the patient may also be in hepatic encephalopathy, so there can be some mental alteration. So that is the reason you have to always look for the A. If you find any confusion with the patient, or you think the patient is in hepatic encephalopathy, is unlikely to save his airway. In the event he again vomits, then intubation has to be done. Okay. Next is breathing. How is breathing important in this patient? Some patients will be in shock, and shock gives rise to metabolic acidosis. Very good. Metabolic acidosis, how will they breathing? Rapid, shallow, okay, so as to expel out the carbon dioxide, okay, to compensate for that metabolic acidosis into respiratory alkalosis. So the patient will become fatigued with that, okay, with that respiratory pattern, thereby also requiring ventilatory support. Okay, so A and B has to be checked quickly. If you don't find anything abnormal with that, then you go with this resuscitation of the C. So how will you resuscitate the C? Circulation. Yes. IV fluids. Yeah. Which IV fluid? Ringer's lactate, normal saline. Two are given in the slides. Which one you will prefer? Ringer's lactate. How many with Ringer's lactate? Rest are with normal saline. Okay. So yeah, Ringer's lactate is a preferred fluid for resuscitation in hemorrhagic shock. Okay. So because why is that? It is a crystalloid which is physiologically similar to the blood. Okay, the pH, the electrolyte composition in the RL is similar to the blood. So that is why whenever it's a hemorrhagic shock, RL is preferred. In burns, RL is preferred. In due to trauma, there is blood loss is there, RL is preferred. In GI bleed, RL is preferred. Okay? Preferably cold, normal, warm, hot, warm. Okay? So warm, Ringer's lactate solution, at least 2 liters, 1 to 2 liters should be infused over the next hour if you find a patient to be in shock. Okay? Or any of the features, it's not that only BP should be low. If the pulse is also high, tachycardia is there, some mental alteration is there, then you can assess that this is probably the patient is in one of the higher classes of hemorrhagic shock, and assuming that you have to give 1 to 2 liters of fluid. Okay, so that's the first step you are going to do. Secure 2 large bore IV cannula. Okay, so large bore means what size? 16 or 18? 16 is which color? Grey color. So can you please see that slide? Yeah. So this is the grey cannula, which is 16 gauge. Okay. Green cannula is 18 gauge. So preferably it should be 16 or 18 gauge. Okay. 2 large bore green cannulas, preferably in the antecubital region. Okay, or on the antecubital fossa. In that you have to secure and give 1 to 2 liters of Ringer's lactate, warm Ringer's lactate over 1 hour, and see how the patient is responding. Now, depending upon the response to the fluids, for that management you are going to do. So this is the like you're buying some time to keep the patient alive until you investigate what is, from where it is bleeding, how much it is bleeding, and whether I should do any surgery for this patient immediately. So it is just going to give you some time. So you have to assess how much loss has happened based on the patient's vitals, and how will you know that how much it is bleeding now? By putting a Ryle's tube. Okay, so Ryle's tube will be inserted to find out how severe the patient is bleeding. Patient must have bled previously, but how is the patient bleeding now? How is the patient, is the source which was bleeding, has it stopped or it is still bleeding? So to find out that, we are going to put a Ryle's tube. Also it will help in giving a gastric lavage if you are planning for an endoscopy. Okay. So I'm saying the events what you're going to, series of events what you'll do when you find a patient coming to you with a casualty and says that he has got an upper GI bleed or is vomiting blood in front of you, or the patient is in shock because of upper GI bleed. Okay. So first what you did is that you assess the airway, breathing, circulation. Okay. For circulation, you have secured 2 large bore IV cannulas. You have given 2 liters of warm Ringer's lactate solution. Okay. Then you are checking the vitals of the patient, how it has improved over the previous vitals when the patient presented to you. Then you are securing the Ryle's tube to find out whether the patient is bleeding again. Okay, if the patient has a continuous bleeding, for that to find out that you are going to put a Ryle's tube. Okay, it will also help in cleaning the stomach before doing an endoscopy. What else you will do? Yes. So to know that your resuscitation is adequate or not, one thing is that you check for the pulse. It's coming down. BP, it's improving. RT, there is no blood. Anything else to find out your resuscitation is adequate or not? Yes? Yeah? Yeah, you can insert a central line that is into the large veins to measure the CVP and thereby find out, but it is not always representative of the perfusion of the tissues. So what is more reliable indicator for perfusion of the tissues? Urine output, very good. So how will you assess the urine output? Yes? Urine output, how are you going to assess it? By putting a Foley self-retaining, which is going to retain, okay, continuous drainage of the bladder by a self-retaining catheter. The name is Foley's catheter. So I'm going to insert it and do a hourly monitoring of this urine output. Fine. So these are the things you're going to do. In the meantime, you're going to investigate. So next comes your investigations. We will move to the investigation. So this everything is fine. Okay, blood. Now when to transfuse blood? The patient who has for old age patients and with hemoglobin around 7-8, we should transfuse blood. But a young patient with a similar hemoglobin may withstand without blood transfusion. Okay, we can manage without blood transfusion also. But if the patient is having a cardiovascular disease, is old age, and RT shows fresh blood, in those cases you are going to transfuse blood. And whenever like larger units of transfusion, say suppose more than 3 or 5 units of blood transfusion is given, we have to transfuse platelets and plasma along with it. Okay, so that is the like how the chapter of blood transfusion and blood products will find out all those things. Okay, like when there is a massive transfusion protocol, how will you transfuse blood? When this 1 or 2 units are required, we need not transfuse platelets or FFPs with it, unless it is a massive transfusion protocol. So investigations. Now patient is somewhat settling. Okay, BP is picking up. Yeah, I forgot to say that in upper GI bleed patients, expecting that patient has got anemia, even if the patient has got a properly secured airway breathing, oxygen has to be administered. Okay, so oxygen to any patient with shock is the dictum. That will help in improving the but oxygen, whatever the oxygen has been carried out within patient with low hemoglobin, that will improve that capacity of the blood. Now, okay. So we have to supplement, give supplemental oxygen either by prongs or with mask. Okay. So now patient is settling. Now you have to investigate to find out what is the from cause, from where it is bleeding, and whether you can do anything for that patient. Okay, so that is what you are going to decide in the casualty. What is the site probably, and what is the cause, what is the site, and probably from whether any surgical intervention is needed for this. Any urgent surgical intervention is needed for this. Okay, these are the things you are going to assess in the casualty. Okay, so what is the cause? How will you find out? Like some points have been given here that from history and examination we will find out what is the probable cause. We can't say it's a definitive that it is this or that unless we go and see do an endoscopy and find it out. So we'll have an idea. Okay, this is acid peptic disease. History is that it's probably an ulcer bleed. Patient is a case of DCLD. Probably it's a varicose bleed. But we should also keep in mind that it could be the opposite also. Okay. So in many of the DCLD cases, we also find non-varicose causes of bleeding. Okay. So we should keep that in mind. Okay. So now you have made an idea that it is okay. Acid peptic disease. What can you give in the casualty to minimize that ongoing bleeding? If anything is there. Yes. Any ulcer was there that is bleeding. What we could have done in the casualty to minimize that bleeding? RT insertion was there. That actually decreases the acid in the stomach, thereby preventing the more further erosion of the bleeding. Sorry? Okay, so sulfate, fine. That is okay. But for a bleeding and decreasing the acid secretion, you have to give pantop infusion. Okay, or high bolus dose of proton pump inhibitors. Okay, or pantoprazole infusion. Bolus dose or infusion, you can give either of these. There are studies on both, but both are effective. Now, if you are taking it to be a varicose bleed, what can you do in the casualty? Octreotide infusion you are going to give. Very good. Along with that, anything else? Yes? Along with octreotide, you have to also give pantoprazole infusion. And if you think that there is a DCLD, which is going into decompensated, is having some altered sensorium, you have to give other drugs like lactulose, antibiotics, and there is a gut antibiotic called rifaximin, which you give usually in patient with suspected varicose bleed. Okay, so these are the things you are going to do in the casualty. And what he has said is that hemoglobin level, he has to find out whether patient needs transfusion or not. PTINR, if it is deranged, we need to correct it. And blood also has to be sent for LFT, RFT, electrolytes, good healing process. Next. Yeah, already mentioned. Yes, next. Yes, next. Okay. Glass. Oh, okay. There are two scores actually given in the books. One is that Blackford bleeding score, and other is a Rockall score. Okay. Okay, you can remember this Blackford bleeding. One of it. Yeah. Next. The Rockall score actually requires endoscopy for scoring, whereas the Blackford can be done without an endoscopy also. It actually indicates the risk of bleeding, re-bleeding. Okay. Patient has come with a bleeding, and what is the risk of re-bleeding? That is given by the Blackford or the Rockall score. Next. Next. Previous. The target INR is 1.5. Okay, not 2.5. This is a reference we got. So yeah, platelets count should, if it is less, should be increased to more than 50,000. Okay. Usually spontaneous bleeding happens when it is less than 20,000. But if you are planning for any intervention, say like endoscopically, some varices are there. Okay, the patient with DCLD will have portal hypertension, and because of that, there may be splenomegaly, and because of the splenomegaly, there may be features of hypersplenism. Hypersplenism includes pancytopenia. Okay, so where platelet counts also will be low. So in that case, we have to give blood products also. Along with that, you have to give platelets to improve it more than 50,000. Okay, platelets should be more than 50,000 or 60,000 before you do any surgical intervention or even endoscopy also. Okay. Yeah, next. Okay. See, the role of prokinetics has not been established. Okay, they say that it can be given to empty the stomach so that we can do an endoscopy. But there is no special recommendations for that. Antifibrillatics also have not been recommended for upper GI bleed, though many centers use it, but there is no definite recommendations for using antifibrillatics. Yeah, ideally endoscopy now what has happened is that you have stabilized the patient. Now you have given blood also if the patient is requiring. We have suspected something, and it is an varicose bleed or non-varicose bleed, and you have given some treatment assuming that it is varicose bleed or non-varicose bleed. Now to find out, to confirm it, we will be doing an endoscopy. So endoscopy should ideally be done within 24 hours. Okay, because if you delay it, the chances of bleeding is there, particularly for the varices, not for the ulcer bleed, but for the varices, the chance of bleeding is there. Okay, the grading of varices has been given, and the Forest classification for ulcer bleed has also been given. Okay, can you show me the Forest classification? Yeah. So 1A, 1B, and 2A have got very high risk of rebleeding. 1A is when there is an active spotting of blood. So what you see is that in endoscopy there is an ulcer, and from that there is blood is spotting out. That is 1A. When there is no spotting but bleeding is there, oozing of blood is there, that is 1B. Then it's 2A. 2A is when there is an adherent, there is a visible vessel. Okay, ulcer is there and you can see the vessel over it, vessel within the ulcer. So these are high risk cases of rebleeding. These cases have a very high risk of rebleeding. So they need your intervention either endoscopically if it is facilities are there within the casualty, or surgery. So that will be discussing in the next class. Okay, what surgery you are going to do or what intervention, endoscopic intervention you are going to do. Then the fourth one, that is 2B, that is adherent clot. So it has got intermediate risk of bleeding. So why it is intermediate? Because you don't know beneath the adherent clot, if you dislodge it, there may be a visible vessel, there may be some vessel which is oozing. So it has been categorized into an intermediate risk of rebleeding. Then other two classes, last two classes, there is black spot ulcer, black spot, and ulcer with a clean base have very low risk of rebleeding. Okay, so these can be managed with PPIs and anti-H. pylori medications. Whereas in the first three, some intervention has to be needed. So now you got to know that you have resuscitated the patient, stabilized the patient, you thought something, and you have given anticipated treatment, medical treatment for this patient. Now to confirm it, you have done an endoscopy, you found out all these things, and now you have also decided whether this patient can be managed endoscopically or surgically. Okay, so this is what you need to do in the casualty. Resuscitate the patient, give if you presume something it is, give anticipatory treatment for that particular cause, and try to maintain the vitals, and also do an endoscopy to find out whether it actually needs something surgical or it can be managed endoscopically, or the patient can go home. Okay. Fine. Yeah. Just 2 minutes on this SBT tube. Okay. I've asked to particularly put this slide. Okay. So it has got two balloons. Okay. One is a gastric balloon and other is a esophageal balloon. So what we do is that a gastric balloon, initially we inflate it with we insert it. This is not inserted through the nose, it is inserted through the mouth. Okay. L tube is inserted through the nose, but SBT is inserted through the mouth. And the patient should be a bit conscious and obeying, so that he can swallow this. Such a tube that it won't go. It is not that rigid. So patient has to swallow the tube. Only then it will go into the stomach. So once it is in the stomach, when you confirm the position of the SBT tip in the stomach, then the distal balloon, that is the gastric balloon, you have to inflate it with around 200 to 400 cc of air. So after inflating air into it, you pull the balloon outside. So what will happen is that it will get stuck in the G junction, and it will apply pressure over the G junction, and so this is helpful not for ulcer bleeding but for varicose bleeding. Okay, so in a varicose bleeding, before you do an endoscopy, if you are thinking the patient is continuously bleeding, I am not able to do an endoscopy, not able to arrange an endoscopy, then in that case, to buy some time before you do an endoscopy and treat it, what we can do is that we can put an SBT, sense taken black motif. So first, the stomach balloon is inflated to 200 to 400 cc of air. It is pulled up so that it applies pressure in the G junction, thereby applying pressure over the gastroesophageal varices. If still bleeding is there, what we can do is that we can inflate the esophageal balloon to around 30 to 40 cc mm of mercury. Okay. Around 40 mm of mercury we inflate it, and yeah, as I said that maximum is 24 hours. We should not keep that SBT tube for more than 24 hours, and otherwise it will give rise to pressure necrosis of the esophagus and GE junction. Okay. So this is what in the casualty you are going to do. You are going to do some investigations, and you are going to do the resuscitation also. Both has to go simultaneously. Okay, it's not that because you want to localize the site of your doing endoscopy and you leave the patient without resuscitation. So resuscitation and investigations have to go side by side. Okay.